So as we begin to look how we're going to make glomerular filtrate. So first of all, in our illustration here on the left, what is the glomerulus?
The capillaries inside the capsule.
The capillaries in here. The capsule, the renal capsule, is the bubble that surrounds the glomerular capillaries. Now, we have an outer layer here of the bubble. What do we call, what layer is that? Bowman's. It's Bowman's capsule, but it's two layers. The parietal layer of the capsule, and where is the visceral layer of the capsule?
The spaghetti.
Those are like the podocytes.
It is the covering over the glomerular capillaries. And those are the podocytes, right. If you want to imagine what that's like, have you ever gotten a balloon? You blow up a balloon, and you take your finger, and you push your finger into the balloon as far as you can without popping it. And the membrane of the balloon just sticks to your finger. And if you look inside, you can see your finger if the balloon is transparent enough. Your finger, and it's covered with the balloon material. That's essentially what we're doing. We've got the membrane on the outside, and then the glomerular capillaries, it's like your finger, and they're covered with that podocyte membrane. All right? So that's going to present the filtration membrane with which we're going to filter blood. And it consists of three parts. Two of the parts are pretty easy, and it's why I like to think of the double stuffed Oreo cookie. What is one of the filtration parts of the membrane? The capillaries of the glomerulus are fenestrated capillaries. So that's filter one. That's on the inside. What's the one on the outside? That's in the middle. The basement membrane is in the middle. That's the one that a lot of people usually forget. The podocytes are the visceral membrane and those slits between. So those are the three filtration layers in here that we're basically going to use to filter everything except the formed elements. Those are going to stay in the blood.
Well, it's also large proteins.
Yeah, pretty big sized proteins, but I just like to think of practically everything. But you do in the basement membrane, you've got the ions that will stick. You've got the type 4 collagen that's going to restrict the size, and that's going to keep the big proteins from actually going through. But for our purposes, most everything other than the formed elements gets out. And the mesangial cells clean out the gunk in the basement membrane when it clogs up.
You said there's really thin membrane between the pedestals of the podocytes, right?
Correct.
What is that thin membrane made of?
Honest to goodness, it's probably phospholipid, but
Okay.
I've never actually known
Okay.
what that membrane was. It's kind of like the fenestrations, those membranes. You know, so I'm pretty sure it's phospholipids.
Okay.
So we have to force or attract the fluid out of the bloodstream and into the space of the capsule. That's going to enter into our urinary plumbing as we make this filtrate. Now, this is kind of review. This is not necessarily new material. Because you remember in our systemic capillaries, filtration and absorption, do you remember that? And we went through osmotic pressure and we went through oncotic pressure. We're doing the same thing here. Because it's going to be these three pressures that are going to dictate where the fluid moves. And so we're looking for a net filtration pressure. Filtration, what did that mean relative to the capillaries? Where was stuff moving relative to capillaries for filtration? Out. So we're going to get the fluid to come out of the capillaries and enter into this first part of the proximal convoluted tubule. That's where it's going to collect after it gets into the capsule. And so that's going to be our net filtration pressure. So let's look at how that works. So with our net filtration pressure and these three factors, we're going to have the hydrostatic pressure in the capillaries of the glomerulus. So that's just our blood pressure. Then we've got the blood osmotic, oncotic pressure, whichever one of those you want to use. And what is within the blood that's causing this to happen?
Plasma?
Certainly the plasma, but what specifically in the plasma? Proteins acting as solutes. Albumin's the primary one. So it's a solute that is attracting water. So we're trying to force fluid out, and this is trying to bring fluid back in. It's those opposing forces. So this would be our hydrostatic pressure from the blood. That is our oncotic pressure from the blood. And then we have the hydrostatic pressure out here in the capsule, which relative to our blood pressure is much lower. So again, we're just adding this one, much like we did with our interstitial pressure in the capillaries, but we don't have an oncotic because this is empty space. So there's not a fourth factor in this particular calculation. So when we go here, our blood pressure in the capillaries is 60. Our blood pressure out in Bowman's capsule is a measly 18. So oncotic pressure being 32, and that's our proteins in the blood trying to bring material in. When you factor all these together like we've done in the past, what we're going to see is that our net filtration pressure is a positive 10. And do you remember what a positive number means? Out filtration. What does a negative number mean? Absorption or reabsorption. But here we've got a positive, so that's our filtration pressure. Now 10 doesn't seem like a lot, but it's enough because we're pushing with our 60 millimeters of mercury blood pressure, pushing against 18. So the 10 is plenty to get the fluid to come out.
And there's millions of these, right? So.
Oh yeah, millions of these glomeruli. And remember, the glomerulus and the capsule together as a unit, do you remember the name for that thing? Renal corpuscle. The renal corpuscle. So yeah, we have millions of these renal corpuscles forcing out that fluid, and that's why we can make 180 liters of filtrate a day. All right. So now we've got our net filtration pressure. And with that pressure, we know if we increase the pressure, we're going to make more filtrate. If we decrease the pressure, we're going to decrease the amount of filtrate we make. So now we can get at a glomerular filtration rate that is a GFR. This glomerular filtration rate is a diagnostic criteria for kidney health. And depending on where you're working, you may encounter this quite a bit. And so what is it? It's how fast you make a certain volume. So it's a rate, volume over time. So as I said, if you increase this pressure, you're going to increase the glomerular filtration rate. Now, this is going to be something like, have you ever floated the river?
Yes, sir.
Now sometimes the river is real lazy. You're floating along, you can observe things on the bank, you can stop. But if you've ever been it after a rain and it's rapids and it's flowing, you're not going to have as much time to enjoy the scenery. Well, if you increase the net filtration pressure and the filtration rate, you're moving more fluid through the tubules faster, and there's going to be much less time to reabsorb the things you need to reabsorb. And so you're going to put more of those, even some of the good stuff, into the urine that you make. So increasing the filtration rate past a certain point is not necessarily a good thing. And one way we're going to see you can do that is by increasing your blood pressure. And it's a big problem in our society today, hypertension or high blood pressure, which can really be a bad thing for your kidneys. Garrett, do you have a question?
Oh, you answered.
I did? Okay. So, when we look at our blood pressure in our glomerulus and the downstream impacts, what we just said, increased blood pressure, you speed up the filtration rate, which means more volume. You can't absorb all the stuff, and you got to be careful about what's coming out in the urine. And so urine can also be a test of kidney function. I know we've had at least 2 moms in here. As you get toward the end of your pregnancy, you're going to have to pee in the top hat every time you go to see the doctor because they're checking your protein level, and they're also, more importantly, checking your glucose level, because gestational diabetes is a big issue and it can lead to a lot of problems for mom and the baby. So that's one way they're checking your kidney health, even during pregnancy. So it all sort of relates and comes together. So is any surprise that the filtration rate is going to be very highly and tightly regulated? Sugar level in your blood. How many hormones regulate sugar level in your blood? Insulin and glucagon, right? What about calcium? How many hormones? 2. What are they? Parathyroid hormone and calcitonin. So we know that sugar, glucose, and calcium are critical. There are going to be a ton of hormones and factors regulating this, which tells you exactly how important it is for your homeostasis and proper health of the human body. So we're still looking at this regulation in our glomerular filtration rate. And we're going to see that this rate is going to be impacted by a lot of things, not the least of which is your hydration status. If you're dehydrated, are you going to produce a lot of urine? No, you're not. If you're stressed, have you ever noticed stress is going to increase your urine production? It does. And there are a lot of other factors that are going to contribute that too. And what we're going to see is that our hormones and factors are directly going to impact specifically your afferent glomerular arteriole. What does afferent mean again?
Arriving.
The A stands for arriving. I like to put in glomerular because that tells you where it's arriving. You dilate that, you increase the flow, you're going to increase your net filtration pressure, you're going to increase filtration rate. If you constrict it, decrease it, you're going to slow it all down.
So would do like natural like vasodilators cause you to pee more then?
Oh, if it's a systemic one, then yeah.
Or like say like you take like an EpiPen, you're gonna have to really go to the bathroom after.
Oh, well, that's totally sympathetic response in emergency. So, yeah, that's going to do it.
Why do people pee themselves when they get like scared? That same reason?
It's a sympathetic response. You're shifting everything to your skeletal muscle in a fight or flight response. I guess if you have a full bladder, you're going to not worry about that smooth muscle so much, that internal sphincter, and the external sphincter might be overwhelmed, or you're just not thinking about it at the time. So, so again, we're talking about the surface area of our afferent arteriole affecting the flow. And here we're going to talk a little bit more about influencing the area of our filtration membranes and the tubules itself. So we're going to talk about intrinsic controls that's happening just inside the kidney proper, and external impactors, which are going to be our extrinsic controls. And this is going to be hormones and other factors. And again, this is not going to be as simple as the 2 we saw for glucose and for calcium. So the first we're going to look at this intrinsic. Since it's inside the kidney itself, think of this as renal. And what does renal refer to?
Kidneys.
Kidney autoregulation. So this one is going to be myogenic. And what do we know myo means? Muscle. And specifically, what muscles are we going to impact in the afferent arteriole? Smooth muscle. Smooth muscle. So this is going to be your autonomic, this is going to be subconscious, and this is almost going to be reflexive that's happening here. So if our blood pressure goes up, and we're getting in a point that we're getting dangerously high in our blood pressure, we need to increase filtration, increase urine production, because what do we have to do?
Get rid of the liquid.
Lower the pressure by getting rid and lowering the blood volume. And so, the afferent arterioles are going to sense the stretch. Those smooth muscles are going to reflexively contract. You got a smaller diameter, so you're going to slow the flow to the glomerulus. What's that going to do to the filtration rate? You're supplying less fluid, so you're going to slow it down. You're going to slow down the glomerular filtration rate because you're not supplying it with as much blood to start with.
What was your question?
Well, what we're trying to do here, because the pressure is so high, if this is dangerously high blood pressure with our hypertension, yeah, we've got to get that down, but you cannot allow too high a pressure to hit those capillaries. Because what smooth muscles do we have supporting capillaries? That's a trick question. None. It's just endothelial cells. So we don't want to blow out the capillaries. So again, this is a time that, yeah, we've got to do something. We've got to get rid of the fluid, but we can't do that at the cost of blowing out the capillaries.
So really that contraction is to protect it
Yeah,
from,
extreme, that dangerously high.
is there like substances that like chemically can destroy the glomerulus, like alcohol or?
Alcohol is really going to hit liver.
Like I've heard people drink for the first time and have like kidney pain.
Anybody want to contribute to that? Because I don't know that one. I know when you drink, you have to go to the bathroom a lot. And that's partly the dehydration, but that's also partly the volume that you're bringing in, liquid volume. So here's the opposite. Again, it's myogenic. Pressure's low. We're going to see that our smooth muscles are going to sense that there's slack. There's not as much stretch. And they're going to respond to that change by relaxing, going to increase the flow into the glomerulus, and that's going to increase the glomerular filtration rate to the basic level. So what we're trying to do in both of these cases is we're trying to make sure, regardless of blood flow, we're trying to maintain the basic level of glomerular filtration rate. Your blood sugar's too high, what's going to be put into your blood? What hormone? Insulin. If it's too low, what's going to go into your blood? Because you want that standard within the range of blood sugar values. Here, we want a basic filtration rate. We're going to do these things to get it back to that level without letting it go too slow, or in the previous slide, without it going too fast. And this is showing your mean arterial blood pressure. There is a huge range between 80 and 180 where your glomerular filtration rate is going to be normalized because it's regulated by this myogenic control. You have to get above 180 for an extended period of time before you're going to make more urine, and it has to get below 80 before you're going to slow down the urine production. And again, we're talking dangerously high and dangerously low.
So if you're exerting yourself at over 180 for a long period of time, you would end up having to...
This is going to be chronic.
Okay. This is
Yeah,
like-
that's going to be chronic.
Not like an
Hypertension.
exercised-induced-
No. This is going to be hypertension and hypotension here. Oh, weren't we just talking about that?
Yes, sir.
So, how can you override the intrinsics? Well, our extrinsic control here, and part of the extrinsic control here is using your brain. Too much fluid intake. You got to increase the glomerular filtration rate. Have you ever heard of individuals dying because they drank too much water?
Yeah.
The contest where you have to keep your hand on the car for an extended period of time, or what is the contest where you just got to drink water and drink water and drink water,
I grew with it when I was like 12.
and they won't let you go to the bathroom or something like that? People die from too much water. To me, that is proof positive that too much of anything can be bad. Most things in moderation are okay as long as they're legal. I want to make sure to get that on tape. Dr. Langford said anything was okay. No, it's not what I said. So in this case, that water balance is absolutely critical, and that's why we have all these controls to help with that. Now, here's a time that you don't have a choice. You've got to decrease your glomerular filtration rate. When you're bleeding out and you're going into shock, you absolutely have to ignore what's happening in the intrinsic system, and that's when the extrinsics take over. So let's look at some more mechanisms. Blood pressure and blood volume, low. We're in bad shape, right? So in this case, We're going to get vasomotor. What is vasomotor? Vaso is what? Blood vessels. And motor is moving, muscle. So here we are in the medulla. What that's going to signal when they receive this information, that's going to signal an increase in sympathetic stimulation. And I think somebody, Hugh, Garrett, one of you talked about sympathetic vasoconstriction. So in this particular case, this is going to cause vasoconstriction of everything, including both arterioles. We talked about the afferent arteriole, which is the other one. The efferent that's exiting the glomerulus. That is going to slow down the fluid coming in, but that's also going to keep the pressure in the kidneys high by not letting it get out as fast. You're trying to maintain the pressure at all cost in a very challenging emergency situation.
What do you mean by also during stress? Like if blood pressure and volume decrease significantly, also during stress?
Well, I think stress is going to contribute because if you've been in a major accident, you're going to be stressed. Your sympathetic response is going, and stress is also a sympathetic response, right?
But that's like the opposite way, though. I thought blood pressure increases, right?
You're bleeding out.
Oh, for bleeding out.
Yeah, I mean you're bleeding out. Your volume is severely going down
Okay,
because, yeah,
I didn't realize we were still talking about bleeding out.
yeah, oh yeah.
No, but we're talking about bleeding out, and is it only the efferent or both?
Well, in this case, both are going to contract because that vasoconstriction is hitting systemically everything.
So normally low blood pressure, low volume, they want to relax, but
Right.
But
In
when
this
the-
case, we're trying to keep from bleeding
but
out.
when it gets dangerously low, it'll try to constrict to save it.
That's right. And again, this is sympathetic. Now, that's one of your responses, the vasoconstriction. The second response, JGA. Do you remember the abbreviation? What does that mean? JGA relative to the kidneys? Juxtaglomerular apparatus. We had those three components. And in this case, our granular cells that are in the afferent arteriole, they are going to produce renin. Now, renin is an enzyme. And what renin is going to do, it's going to be active in activating what is called the renin-angiotensin-aldosterone pathway. Renin is going to take a precursor to angiotensin, which is angiotensinogen, and guess what it's going to clip off? The OGen. So it's going to activate this plasma molecule that is then eventually, and we're not going to do the whole pathway, we're going to get to angiotensin 2. Angiotensin 2 is going to lead to continued vasoconstriction, and we're also going to influence the ability of your kidney to reabsorb materials. And so in this case, when your blood pressure is low, angiotensin is going to cause you to reabsorb more fluid. So the vasoconstriction is going to cause you to decrease glomerular filtration rate. The angiotensin and aldosterone that we're going to see in a little bit, it's going to be activated here as well. That's all going to cause you to retain more water to try to keep that blood pressure up. There's only going to be one instance where we're going to have a factor that's going to function when your blood pressure's too high. The rest are all geared at basically you're bleeding out, sort of emergency.
What role does antidiuretic hormone play in all this, if any?
We'll get to that more when we get to the collecting tubule. Most of this stuff is working in the nephron. When we get to the collecting tubule,
Like almost
that's where we'll see
specifically
ADH.
Specifically the renal corpuscle.
Yeah, well, this is not so much renal corpuscle. This is the arterioles. And these are going to influence proximal convoluted tubule, distal convoluted tubule, principally where we're going to see these. Oh, right here, this is what I was talking about. If now your blood pressure and volume are too high, and when we say high, we're meaning dramatically high, you're going to have too much blood. What is an organ that you can think of that should be intimately available to sense what's going on with the blood and the blood volume? The heart. You don't think of the heart as being a secretory organ, right? You think of it as a pump. But remember your heart. The more you fill a ventricle with blood, what is going to happen to the strength of the contraction? It's going to increase because you've stretched those sarcomeres. You've stretched the skeletal muscle. So that muscle intrinsically, automatically is going to contract harder. The other thing that's going to happen is if you stretch too much in the heart, and this would be in the atria, you're going to cause the release of atrial natriuretic peptide, ANP. Now again, this is in response to high blood volume and high blood pressure, and atrial natriuretic peptide is going to cause vasodilation, systemic vasodilation, including the arterioles, your glomerular arterioles. So when you hit that, what's going to happen to the glomerular filtration rate? It's going to go up, not to the basic level, it's going to exceed the basic level because we're putting way too much pressure on the body and way too much pressure on the heart. Now we're in an emergency setting here. And so atrial natriuretic peptide, it's the only factor we are going to talk about that causes you to produce more urine to lower pressure. Everything else is working against low pressure and low volume to sustain your body. Okay, did you hear all that? Because trying to remember a lot of these factors and which way they go can get confusing. This is the only one that works to lower your pressure when it's too high. And what kind of feedback is that?
Negative.
Negative feedback. We learned that the very first week of A&P1 and we're still playing with it. Negative feedback loop. So too high a pressure, you're going to increase urine production in order to decrease your blood volume and the blood pressure. And again, now we're talking about extrinsic overriding what we've been doing with the autoregulation myogenically.
So if we could like summarize it in one sentence, what would that be?
Atrial natriuretic peptide.
Just the intrinsic versus extrinsic.
Intrinsic is just the smooth muscle and arterioles responding to stretch automatically. The extrinsic are above and beyond what the intrinsics would do.
Okay.
The intrinsics are going to do their thing no matter what. You might be bleeding out. They don't care. The extrinsic is going to go above and beyond what the intrinsic is doing. Okay. All right. So we did filtration, right? Filtration in the renal corpuscle. And we know filtration means what relative to the capillary? It's going out. Now we're going to look at reabsorption in our nephron, principally the nephron, where we bring materials in which direction relative to the blood. Its absorption is bringing it back into the blood. Because remember, we had 180 liters of filtrate. We don't make that much urine, right? So we're going to reabsorb all but about a liter of the fluid and the other stuff that's in that fluid. So we're going to talk about reabsorption. But here's another one we're going to talk about. And it's going to be called secretion. Filtration and secretion sound kind of alike, right? They're not really alike. We've got our filtration in the glomerulus, our reabsorption, bringing it back into the blood. But secretion is where you take materials, and in this case, we're going to have materials that are, excuse me, here we've got our purple. That's going to be going back into the blood. See, filtration here is the green. Purple is going to be absorption or reabsorption. But the yellow is going to be another opportunity where we're bringing materials out of the blood and putting them into the filtrate/urine. And where we're getting away from filtration here is since we have this terminology specifically at the glomerulus and those capillaries, here in our peritubular capillaries and in our vasa rectae, we're going to use the term secretion. You see the difference? It's a locational difference more than anything else. And so if we need to add more materials to the filtrate that didn't make it out of the filtrate here in the glomerulus, we're going to do that by secretion. And these things are typically going to be either inherently active here based on diffusion or active transport. And that's what's going to lead to this primarily happening. And we're going to see this a lot with our pH balance as we look at how things are moved. So what do we call this thing here? That is the corpuscle, the capsule plus the glomerulus. What is this part?
Proximal convoluted tube.
Proximal convoluted tubule. Because it's proximal, it's close to the glomerulus. I'm going to skip this. What do we call this part? Distal convoluted tubule. And in fact, does the distal convoluted tubule, is it further away necessarily from the glomerulus? No. It's going to pass right back by its own glomerulus, but when you look at the path of the filtrate flow, it is further away. All right? But this thing's going to swerve back around. What do we call this loop in the middle?
Nephron loop.
What's a word or what's a name that means the middle loop? Intermediate loop. It's the intermediate loop, loop of Henle, nephron loop. There are a lot of terms. Intermediate loop just simply means the loop in the middle. All right? So when we look at our nephron, we're going to see that there's substances that get completely reabsorbed back into the body. You've got to have these things to keep homeostasis rolling. So glucose is one of those things that we're going to see is completely reabsorbed. You should not find sugar in your urine under normal conditions. If you have diabetes, yes. Sometimes in pregnancy, as we've already mentioned, toward the end of the term, you could see glucose appearing in your urine, and that signals sort of the mom's health and the baby's health.
Where is this? Okay.
Oh, we're gonna take a lot of these individually.
No, but like where, like, is the substance being reabsorbed completely? Where does that occur?
That's where we're going to get to that.
Okay.
Yeah, we're going to talk about proteins, and we're going to talk about ions, and
Like which section of the nephron?
exactly, we're going to take those individually. Yeah, this is just kind of an overview right here. We're going to also see that substances have to be regulated in how they are reabsorbed. So we can't store them necessarily. And so we're going to use hormones to try to balance this out. If we have too much, we're going to excrete them. If we have too little, we're going to reabsorb them more quickly. And so an example of that type of material is going to be potassium. Now, we haven't talked about potassium a whole lot. Where's the one place that we always talk about potassium? Sodium-potassium pump. Between ANP1 and ANP2, do you understand how ubiquitous that pump is? It is almost in everything we talk about. So potassium is balancing out sodium. They have the same charges. But another important aspect of potassium that you may or may not be familiar with, if you have too much potassium in your blood or too little potassium in your blood, you could be in store for something that's not very healthy. Does anyone know what's going to happen to you if it's too high or too low?
Hyperkalemia.
Well, that's going to be more any ion change, but there's one specific muscle that is not going to like potassium being out of balance.
Heart.
Your heart. You will have heart arrhythmias if your potassium level gets out of balance. So that's why this is fairly tightly regulated, especially with the hormones that we have in your body. Now, last, we got some we don't want. We're just going to get rid of them. Just eliminate them as waste completely. So where does this happen? Garrett, to get to your question, we're going to start substances reabsorbed completely in the proximal convoluted tubule. All glucose, amino acids, some vitamins, and we're putting ETC there, other things too. We're just going to cover those important ones. Those are completely reabsorbed in the proximal convoluted tubule. As soon as they hit, they go into the blood. We get them out right away. It's just too important.
So the entirety of filtration doesn't happen in the glomerulus. It happens,
Filtration is going to happen in the glomerulus.
but reabsorption.
Reabsorption, it's going to be in other places, not just the proximal convoluted tubule, but a lot is going to happen right there. Yeah, I mean, just right away. And most of this is going to be diffusion. And if we're going to diffuse through transport proteins, what kind of diffusion do we call that? Facilitated diffusion. We use a protein. Don't forget, just because you use a protein doesn't make it active. Because remember, we're going high to low. That's diffusion. What's the other transport that goes low to high?
Active transport.
Active transport, and you got to have energy for that. We're not using energy for that. Diffusion is passive. Now, there are some small proteins that we're going to bring into the cell, and we're going to do that, and we're going to break them down. So if it's too big, well, in this case, even some of these proteins are not necessarily going to have transport protein channels. We're going to break them down first. Then we're going to allow them to diffuse back into and reabsorb into the bloodstream, because we need proteins, we need amino acids so that we can begin to build the new proteins that we need. Here's another one. This is going to be the regulated absorption, not the complete reabsorption. It's going to be regulated. And when we look at the proximal convoluted tubule, still most of our reabsorption of sodium is going to occur there, but we're going to reabsorb the rest, well, close to the rest, here. This we're going to reabsorb because where sodium goes, who's going to follow passively? Chloride. And when you get sodium chloride somewhere, what's going to follow the sodium and chloride? Water. That's going to be part of our water reabsorption because we can move the sodium. Now, we got 65, 25, 90, so 10% or so of sodium reabsorption is going to be hormonally regulated. This is said to be constitutive reabsorption. Do you know what constitutively means? It's always going to happen. It's not regulated. It's going to happen no matter what. So only 10% is going to be regulated by our hormones.
10% is being reabsorbed, or how
No. We're going to get most of the sodium reabsorbed.
So 90%.
10% you can either increase, you can reabsorb all 10%, or you can decrease that amount depending on the needs of the body.
Okay.
But 90% of the sodium is going back in no matter what.
Okay.
You got 10% to play with.
Okay.
So proximal convoluted tubule, where we have the 65%, you can see over here in our diagram, sodium is high concentration outside the cell. So we're going to bring that in to our proximal convoluted tubule cell. Okay, and they just say tubular cell. And once we bring it in, now we got low sodium inside, high sodium outside. How are we going to get the sodium out to get it into the blood?
Sodium potassium pump.
Active transport, sodium potassium pump. And once the pump gets it into the interstitial spaces here between the capillary, the peritubular capillary, and the tubular cell, now we're going to diffuse out of that and into the bloodstream, because now we got high sodium out, low sodium in the capillary, so whoop, it just diffuses in. And that's how we reabsorb that 65% of the sodium in the proximal convoluted tubule. Distal convoluted tubule, this amount, because remember we got 25 down here in our loop, and that's also going to be sodium potassium pump. But here this final amount is going to be controlled by hormones, not the least of which is aldosterone. And do you remember aldosterone from when we looked at our hormones and the adrenal cortex? Okay, this is one of those mineralocorticoids. And what we're going to see is this hormone will increase the synthesis of some sodium channels. You remember our voltage-gated sodium channels? And also our sodium-potassium pumps. This is going to be in our collecting duct. And what's going to happen here is those principal cells, these are the tubular cells that line that collecting duct, that is going to cause increased sodium reabsorption. And like we see here in the loop of Henle, or the intermediate loop, when you send out sodium, chloride's going to follow, and then water's going to follow. And that's one way we're going to reabsorb more water. By increasing or decreasing the regulation of sodium, we're going to increase or decrease the regulation of osmosis of water. And that's based on aldosterone. If you reabsorb more sodium, you're going to reabsorb more water, and that's going to decrease your urine production. Because again, remember, what's the only factor that causes you to make more urine to offset high blood pressure? Atrial natriuretic peptide. Everything else is going to cause you to make less urine and increase your pressure. Once you get that mindset, it's going to be easier to follow these different factors. Okay? So, here's a couple of little sayings. All right? Aldosterone, al likes salt and water. So aldosterone, because al likes salt and water, that means we're going to keep it. We're not putting it into the urine. Okay? So aldosterone works on the salt and the water follows. And that's aldosterone. Now, here's our atrial natriuretic peptide again. What is atrial natriuretic peptide going to do?
It's going to prevent.
Increase urine to lower our pressure. It's the only one that does that, right? So, here we're going, this is that regulated aspect over here. We're going to decrease the reabsorption. That's going to increase our urine production by keeping more water in. So atrial natriuretic, Nate, hates salt. And if Nate hates salt, it's not going to keep it. It's going to get rid of it. And in doing so, it gets rid of water. If that helps, it helps. If it doesn't, sorry?
You get sort of salt and water or just
Well, wherever salt goes, water's going to go. Okay? Now, regulated reabsorption. Here we are with water. 65%, again, proximal convoluted tubule, most of it. Here in our intermediate loop, constitutively 10%. So now we're 75%. So we have the remainder of the water to reabsorb here in the latter part of our nephron, and more specifically over here, our collecting tubule. This is where we are going to have our regulated water reabsorption. So, in the proximal convoluted tubule, sodium goes, water's going to go. And again, when we look at what's happening with our 65%, you can either call it constitutive water reabsorption, or in this case, obligatory. It's going to happen no matter what. Distal convoluted tubule and collecting ducts, we're going to see that water really can't diffuse in either one of these over here on the end. And we're going to get to this when we talk about our countercurrent multiplier. And we're going to save that for Thursday. It's a little bit of heavy lifting and moving for that one, so we're not going to have that on the quiz. We'll be able to talk about that much more and spend more time on it. But if we have little permeability, how are we going to regulate water reabsorption? Well, what we're going to see here is aldosterone. Again, we've already talked about al. Al likes what? Salt and water. So that's going to help with this. But if we're not so permeable, how's the water going to get out? That's the big question. And here's the ADH. Who asked me the ADH earlier? So antidiuretic hormone, ADH, that is going to work such that antidiuretic hormone, when it's produced in increasing amounts, it's going to increase the number of these protein channels that are within the membrane of our collecting tubule cells. And these protein channels are called aquaporins. What do you think is going to flow through aquaporins? It's a water hole. So you're poking a water hole in the membrane, and which direction is the water going to go? Why? Because that's where we're moving the sodium and the chloride. So it's going to pass through that aquaporin by diffusion. So aquaporins are what kind of transport protein?
Passive or
Passive, osmosis, but it's going through a protein, so
facilitate?
facilitated diffusion. Aquaporins allow facilitated diffusion or facilitated osmosis of water. And they're following the sodium and chloride because of what aldosterone did. So they're working together. Yeah, here.
What was the role of aldosterone in the DCT and the drugs again?
Salt. Get the salt out there, but remember, we're putting the salt out to attract the water and to reabsorb the sodium, but the cells aren't permeable to water. That's why we have to have the water holes. And more of those get put there because of antidiuretic hormone.
So both aldosterone and ADH help in response.
They're working together in this case. So that we can reabsorb more water, decrease the volume of urine, we still have that obligatory water loss, which is going to be about 300 to 500 mils a day you have to make to get the waste out. It's just going to be really concentrated. Has anyone ever been so dehydrated that instead of bright yellow, your urine was turning brown? This is severe hydration. Listen, okay. Okay, there's mostly ladies in here, so guys, I'm just going to admit it. Guys sometimes aren't that smart. Okay? You're married. You know sometimes guys are not so smart. So in addition to a lot of other stuff that I've done, that if it's just fun, I'm going to do it. I mean, I'm on the radio. I teach biology. For 8 years, I was a high school football referee. I love football. I'm a little too old to play it anymore, but I can actually be around it. In one of the locker rooms at this high school, where the officials got to change and dress and everything, in the bathroom, on the wall behind the urinals, there is a poster that shows the different colors of urine and what it means. Have you seen these before?
Yeah, they have them here in the
And I was just astounded that this really, really dark chocolate milk brown and red on the poster said, "Seek medical help immediately." Why do kids need a poster that if you're basically urinating chocolate milk, you don't know something's wrong? Is it just me or? But here's the thing. You are all, most of you nursing, we got some other allied health folks in here. You are going to be amazed at what you are going to come across. We got some EMT type folks, right? Have you come across some stuff that you just go, what were you thinking? Yeah. So just be prepared for certain levels of just, you feel like people are shutting their brain off. But there may be a lot of factors going on in play.
I've seen that brown in like a, what is it, a catheter bag?
Yeah.
We had like a car accident patient who had
Yeah.
a blood pressure of like 70.
Woo, 70?
Systolic of like 70. And so
Good
he
Lord.
isn't peeing.
Yeah. His urinary hormone system, they were in overdrive. Aldosterone and everything except anti-natriuretic peptide. All right. Yeah.
Okay, so aldosterone does not signal ADH to do anything?
No. ADH is hypothalamus. But in this case, they're working together. Yeah. All right, so now regulated reabsorption. Looking at potassium, we said potassium was important, right? You don't want cardiac arrhythmias. And you need potassium to offset sodium with the sodium-potassium pump. And you know we need a lot, because there are a lot of sodium-potassium pumps in everything. So in the proximal convoluted tubule, we are absorbing sodium, right? 65% or so of the sodium in the proximal convoluted tubule. So sodium and chloride, right? Water's going to follow that. And in this case, the water and the sodium and the chloride are also going to be pulling potassium along with it. Now, here's the thing. It's going to be between the proximal convoluted tubule cells, and it's going to pull it between based on this sort of osmotic gradient and the water flowing. It's going to pull it between into the interstitial fluid, and this is kind of a unique type of transport because this is referred to as solvent drag. Now, it's political season, right? Have you been spared any of these ads and texts and yeah, I'm ready for the whole thing to be over, but we got a long way to go. Have you heard of riding on somebody's coattails? Yes. Have you heard that saying? Yes. Basically, that means you've got some famous person, some rich person, and you really aren't very important, but you're just going along with them. You're walking behind them, riding on their coattails. Well, that's what potassium is doing here to be reabsorbed up to 80% in the proximal convoluted tubule. Now, we're going to cover some of these, but magnesium, calcium, phosphate, chloride, these are principally doing the same thing in the proximal convoluted tubule. Again, most everything is primarily reabsorbed in the proximal convoluted tubule. But we do have a component here that is going to be regulated. So, distal convoluted tubule. We've got al again. And so aldosterone, if you have a lot of potassium in the blood, aldosterone is going to increase the sodium-potassium pumps. Why in the world would you do that? Solvent drag. You're getting the sodium going, you're getting the chloride going, you're getting the water going, and potassium goes along with it. And in this case, the principal cells are going to be offsetting the sodium-potassium pump, right? So when the sodium goes out into the interstitial spaces, we've got to bring the potassium in to offset it. And when you bring potassium into the cells, the principal cells are going to spit it out into the tubule. And you're going to excrete it. Whoops, did I go too fast? Yeah, you're going to excrete it. If it's too high, we don't want it in the blood. We got to get rid of it. And we're going to get rid of that in the distal convoluted tubule, not by filtration. Where does filtration, the only place it happens? In the renal corpuscle, the capillaries of the glomerulus. The glomerular filtrate. So we're in distal convoluted tubule. To get rid of it, it's got to be by secretion. And so that's where we get rid of the potassium.
So even though the increased pumps is increasing the amount of potassium coming in, these principal cells are...
The cells are spitting it out the other end into the filtrate.
So I thought potassium would be going into the filtrate and sodium would be coming...
Well, sodium, remember, we're reabsorbing sodium, so it's coming out of the cells. We're getting it out of the filtrate. The cells are putting it into the interstitium.
Okay.
So what we're doing is we're forcing potassium to go the other direction because potassium and sodium are opposite.
Yeah, so they're going into the filtrate.
They're going into the filtrate because you got too much in the blood.
And then...
And we're using this because this is the one way we can get potassium to go where we need it to go.
But how is it get, if it's going in the filtrate, then if it's...
We're getting it out of the body because we got too much in the body.
Oh, if...
Yeah, too much in the body. All right, calcium and phosphate. You know, calcium phosphate, they're kind of joined together like sodium and chloride, and you can kind of consider them that way. And so in this case, when you look at calcium, 70% in the proximal convoluted, phosphate 80%. We've got about 20% or so calcium in the intermediate loop. Not really a lot of phosphate happening here. And then roughly 10% of the calcium and phosphate in the distal convoluted tubule as we move down toward the end of the nephron and we get closer to our collecting tubule.
So most reabsorption happens in the PCT?
Correct. Most of everything is reabsorbed in the PCT. Maybe not completely here. Protein and some of those other factors are completely reabsorbed here, but the majority of everything else is reabsorbed there. And we don't have to really regulate this in our urine output, because where do we regulate calcium and phosphate? Because we can store them in the bone. We can store more or bring more into the blood if we need it. So that's why we don't have such a huge regulation of it. Oh, and here's what we're talking about. We got our calcitonin for calcium, parathormone. We already talked about it. Calcitrol, yeah, okay, we'll give you that. Vitamin D, all right? And again, this is going to be working on the bone, because we can reabsorb more in the bone. We can deposit more into the bone. We've also got that constitutive reabsorption that happens in the kidneys. And we can have absorption by the gastrointestinal tract, right? By getting your calcium in your diet. So if we're low in calcium, we get more in our diet, then we can balance that out. Okay? So parathormone, again, that's going to regulate our calcium, and to a lesser degree, phosphate. We have low calcium, parathormone's released. You're going to cause decreased reabsorption, and it's also going to affect that phosphate, distal convoluted tubule, increase reabsorption of calcium, increases the blood calcium.
So why do we have to decrease blood phosphate?
Well, in this case, this is going to offset what we need with the low calcium. Since these are kind of both considered together, so if we're going to be bringing in the calcium to increase it in the blood, in the proximal convoluted tubule, we're going to offset that by decreasing the reabsorption of potassium.
Is
Now,
calcium phosphate something you find in the blood? Or is it just
I don't think necessarily. They're often considered together, just like sodium and chloride. They're not always together in the blood. In the kidneys, when you transport them out, they tend to follow one another as ions. So as we do this in the proximal and the distal, with the phosphate, as we eliminate that in the urine, then that's going to be much less present to form the calcium phosphate. And in doing so, that's going to decrease the amount of calcium that actually goes to the bone, because where else do we need calcium? Where else in the body have we talked about needing calcium?
muscles?
You got to have calcium for muscles. If you don't have calcium in the muscle, you're not going to contract, right? Where else do we need calcium? Well, not the bones. Okay, we're not talking about the bones here, every place else but bones.
Nervous system?
Where in the nervous system? Oh, you were just naming systems.
No, I know. I didn't forget.
Isn't it whenever the synapses?
As the action potential is coming down the axon, when it gets to the synaptic knob, the terminal bouton, that's when you have calcium voltage gated channels. Calcium comes in and that begins the signaling to the release of the neurotransmitters. So you can't just have the calcium phosphates that you have in bone. Calcium ion is going to be needed in so many other places to maintain proper function. So this is the balancing act, and that's when your calcium is low, you get rid of the phosphate so we can go to other places other than the bones. Because these other factors, keeping your muscles working like your heart and the nervous system working, it's much more important than your bones at this point.
So
There it is.
basically say stop building bone, keep it in the blood.
Correct. If your calcium gets too low. And not that low calcium is a cause of it, but females in their older years, what is a bone condition that they're affected by? Osteoporosis. Actually, bone that is holy, that's what that name means. And what's happening is, based on hormonal changes, you're reabsorbing more bone than you're depositing. What cells remove bone, do you remember? Osteoclasts. Remember, blasts are the babies. Osteoclasts, they're more active. And so you're removing too much. And in this case, it can be really detrimental. So that's a extreme example of how you can survive with weak bones, just because everything else needs the free calcium. Osteoporosis is not that case. It's just a hormonal imbalance between the estrogens and the progesterones. We're going to save this for next time. Yeah, if I insist. We got a couple of 10 minutes. If y'all have questions about last time or this time, we got the quiz. We got the quiz next time. So any questions?